Good afternoon. Welcome to UCSF Department of Medicine Grand Rounds. Welcome back. We have been off for a few months, and the last Grand Rounds we had, I think, was in late June, and we did a COVID summary, and I made the point that we'll do them again when we need to. I didn't know when we'd need to, but it seems like a ton of stuff has happened over the summer, and so we thought it would be terrific to start our fall season and our new academic year of medical Grand Rounds with a summer-fall COVID update. A lot has happened, new variants, a new vaccine. As some of you know, I got COVID for the first time and had a fairly eventful case, and lots of people I've heard have gotten it for the first time. And so a lot going on. We thought it was worth talking about it. And to do that, we have reconvened the band. This is a group, over the last 3 or 4 years, we've had several experts from UCSF and from outside UCSF be our COVID discussants, but this was our most common group of folks who do it quite wonderfully and have three, I think, fairly often different but very mutually respectful perspectives on the pandemic. And so this felt like the right group to reconvene and start us off as we think about the state of COVID in September 2023. So I will make the introductions very short. You know all of them. Peter Chin-Hung is professor of medicine in our Division of Infectious Diseases. He's also associate dean for regional campuses for the School of Medicine. Peter's a superb medical educator. He's won many teaching awards. And for the last 3 or 4 years, he's been one of the go-to communicators on all things COVID, both locally, nationally, internationally, a ton of media. And a lot of people look to Peter to figure out what's going on. So we will do that again today. Another go-to communicator in the COVID pandemic is Monica Gandhi. Monica is also professor of medicine, also in our Division of Infectious Disease based at Zuckerberg San Francisco General Hospital. She has a number of leadership roles, including director of the UCSF Center for AIDS Research, medical director of Ward 86, which is the HIV clinic at the county. She's an accomplished researcher in all things related to infectious diseases, particular focus on HIV and TB. She was co-chair of the International AIDS Conference a couple of years ago. And she has a new book that just came out from the Mayo Clinic Press called Endemic, a Post-Pandemic Playbook, where she describes what we got right and didn't get right during the pandemic, and I highly recommend it. It's a terrific book. Finally, last but not least, we bring back George Rutherford. People have been wondering where George went for the past year. George has been in London at the London School of Tropical Medicine and Hygiene on sabbatical. We're thrilled that he has returned. He's professor of epidemiology, preventative medicine, pediatrics, and history, and now the acting executive director of the UCSF Institute for Global Health Sciences. And George is a world-renowned epidemiologist in all matters of infectious diseases, but for the last 3 or 4 years, he has really been the go-to source for us and for many other people about the state of the pandemic and what the numbers mean. So today will be a discussion, but we'll launch it, as we have so many of these, with a brief presentation by George about the state of the pandemic. And I'm interested to see this because many of the numbers that we've been following for the past 3 or 4 years no longer exist. So it'll be wonderful to figure out how George is following the state of the pandemic. So George, welcome.
Thanks, Bob. I didn't actually realize these were done in person ever. So, it's nice. It's great. May I have the first slide, please? Okay. So last week, headlines in the New York Times: not over yet, late summer COVID wave brings warning of more to come. This is kind of reading the tea leaves for COVID is a real science, kind of like astrology. There's a lot in the eye of the beholder, and there's a lot of interpretation that goes on, but this is kind of CDC's current thinking that we are in a small COVID surge. I referred to it today on the radio, my first interview since I've been back, as modest, which I think is a reasonable term. But it is nonetheless happening. So this is what's going on worldwide. This is, as you can see, it's really leveled out and gone way down. The purple is the Western Pacific, which is mostly the People's Republic of China, which had a huge COVID surge after they took their foot off the brakes and decided to move from their zero COVID policy to one that looks much more like what we have. But overall, aside from that, you can see, and even including that, you can see this tapering off. Now, I would say that this is all based on reported cases. The region of the Americas, which is North and South America, no longer reports individual case counts, mostly because the counts have become so meaningless because we don't have laboratory-based reporting anymore. Okay, just to put a couple of more points here about China. This is a very real surge in China. At PKU is at Peking University. These are both from Peking, and then the other the triangles are from Heilongjiang, province. But this was also associated with an increase in internet traffic in China around words like crematorium and funerals and what was the other one? Anyway, you get it. So this is real. It's been corroborated. John Ioannidis at Stanford has done some estimates about the numbers of excess deaths, but there are a lot. Closer to home, this is what we're talking about. This little blip up here at the left, at the bottom right, these are in hospitalizations. These are new hospitalizations for COVID, not with COVID, but for COVID, right? And that's a distinction because when someone comes in to get a hip replacement, they'll get screened. Are we still screening them all, Peter? They used to get screened. Some places screen them. So you end up with people who are being hospitalized or who are being seen for hospitalization who have an incidental finding of COVID. But these are real diagnoses. So you can see that it has gone up starting in the kind of late-ish summer, June, July, but that it's relatively small compared to some of the other big peaks we have. It has not been accompanied yet by an increase in deaths, at least the deaths that we've been able to ascertain. Sorry, it's reactive airway disease, don't worry. Mortality overall continues to fall, and part of that is that the case fatality rate with the Omicron strains is lower than it has been with the earlier strains, particularly Delta and the early Alpha strains, which is more to the left. So you can see even if you look at hospitalizations primarily for COVID, again, the scenario where they're actually hospitalized for COVID, the case fatality rate has continued to fall. This is the most interesting little tidbit that I've come up with recently, which is the excess deaths by political party affiliation in Ohio and Florida, two bellwether states. And this was done basically trying to look at mortality. And what you can see if you look at the far right-hand corner is that in counties in Ohio and Florida where there was an excess of deaths, you could sort by who won the primary by registered voters, and the mortality rate's about 15% higher in counties with predominantly Republican voters versus those with predominantly Democratic voters, and this has spun off a whole series of conspiracy theories about trying to fix the 2024 election by selective reduction of the pool of Republican voters. I kid you not. And JAMA actually published this, which was more interesting. But we've really started, because just remember that when the US government mailed out test kits to every household in the country in February of 2022, basically at that point in time, our ability to count cases vanished overnight. So case counts became meaningless because people would just, do the test, do whatever they're going to do with it, and you would never know what the results were. We're really limited to in-hospital tests for the case reporting system, which is a small fraction of all cases. So we've really lost the ability to count cases. One of the things that we've replaced it with is looking at wastewater surveillance. Now, how does COVID get into wastewater? Well, you swallow secretions, respiratory secretions, and you can actually measure by PCR COVID fractions in fecal waste. This is looking at big sewage treatment plants in the U.S. These things are complicated to read, but if you look at the red and the orange, these are ones where it's kind of mostly increasing, as opposed to the yellow, which is stable, and the blue, which is decreasing. You can see it kind of crossed the 50% mark of, if you look around the country, where it's actually increasing. And this is viewed as corroboration for the hospital data, although it's kind of difficult to read, and it's not generalized across the country. What we do know is that the variants are changing, and I'm sure Peter and Monica will talk about this a lot. We have the emergence of something called EG.5, and which is now representing about 21% of all, or 22% of all isolates in the U.S. that have been typed, which is not a random sample, I will point out quickly. But this is what we're kind of basing things on. What's gone into the vaccine is the XBB 1.5 and or 1.6 strains, which were kind of earlier summer strains. But the good news is that the spike proteins, which is what we're trying to force antibodies to using mRNA technology, are pretty much the same. They're not big sequence differences, and they seem to have very similar immunogenic properties. There is a new strain, and I can't remember its name right off the top of my head. It's like 0.95. Sorry, say it again? BA286. I thought 95. Oh, well. And famous medical journal New York Times reports today that you still get 7 to 8-fold increase in antibody boost. So there's a lot of homology across these spike proteins. And I think that we're probably in relatively good shape for the new vaccine that's coming. Now, I think that it's worthwhile to go back and do sort of a postmortem on the vaccines, which I'm sure Monica's book covers in detail. This is what we're estimating in the United States as the number of lives saved from the vaccination program through November 2022, and the deaths averted is 3.3 million. The hospitalizations reported is 18.5 million. Infections reported 120 million. So this is a big deal. And these are all models, obviously, but I think they're probably not unreasonable models. WHO did something very similar worldwide and estimated that worldwide there were 19.8 million deaths averted, which were not all in high-income countries. There are quite a few in lower middle-income countries and upper middle-income countries, and upper middle-income countries like maybe Croatia, lower middle-income countries maybe like South Africa. Okay. So now the benefits have not accrued to low-income countries, obviously, because there's just not a lot of vaccination. But in many countries in the world, you have seen vaccine benefit. Now, what about the new vaccines? The current recommendations, this is as of today, the current recommendations that anybody 6 months of age or older should receive a primary series and a booster of mRNA, a booster with an mRNA vaccine. The primary series can be with Novavax. Everybody 50 and older or 12 years and older with a moderate or severe immunosuppression should receive a 4th dose. Okay? Now, the new bivalent vaccine that you're all waiting for is going to be here next week, maybe, week after next, maybe, sometime mid to late September. It has both the ancestral strains and the XBB 1.5 in it. Again, as I said, is EG5 spike protein is highly similar to those of the XBB sublineages. We should be okay, even though EG5 is pushing into the population. But I will point out that only 17% of the US population has received a booster dose at all. And even people over 60, it's not that many. It's maybe 35%. Is it 50, up to 50? Yeah. But it means 50% haven't. You know, like, what's the story, right? So if you're due for a bivalent booster, I'd suggest waiting a week or two. I've fielded questions, well, I'm going to Europe next week. Should I just get the vaccine anyway? You know, it's a, you know, oh, by the way, it takes 2 weeks for it to work, or some number of days. You don't get instant immunity. So you need to build that into your schemes. Again, I will say don't forget your influenza vaccine. And for those of you 60 years and older, or between 32 and 36 weeks gestation, you should get an RSV vaccine too. RSV is a big cause. I'm a pediatric ID, so RSV is a huge cause of pediatric pulmonary disease, but it's also a surprisingly large cause of adult pulmonary disease. And so I'd be very much on the bandwagon for getting this. How does it all end? I've shown you this slide before. In 1889, there was a strain of influenza called the Russian flu that had a very similar epidemiology to coronavirus. And the thought is that that was a beta coronavirus outbreak. We're still rounding up. Oh, you missed the part about 32 to 36 weeks pregnant. So, okay, sorry. I can repeat that for you. The thought is that that represents the OC43 strain, which is one of the circulating beta coronaviruses. So this, over the 140 years, this has evolved into the population to something that's relatively benign, as we're kind of seeing if you follow the case fatality rates. That's where we are right now today, and I'll turn it back to Bob.
Great. Thank you, George. So why don't we turn to Monica and Peter, just why don't you give us your current take on the state of the epidemic, pandemic, or what are you calling it? Your book is called Endemic, so maybe that's what you're calling it. Why don't we start with Monica?
I think it's almost a man-made definition what you decide, right? Is a pandemic, endemic? But I think in traditional infectious disease epidemiology, there are four things that you want to do. You want to either get to control, elimination, eradication, or extinction. And nothing has been extinct, because if we destroyed the smallpox laboratory supplies, that would be extinct. But only one virus has ever been eradicated in humans, which is smallpox. You point out rinderpest in cattle, but they aren't human. And so...
You knew where I was going with that.
I know you were going to... but they shot the cattle. So only smallpox has been eradicated, and then you try to say, okay, could we eliminate or control? And the reason that George just said at the end that we will never even eliminate COVID is because of 5 different reasons. It's really mainly that all the animal reservoirs. We killed 17 million mink in Denmark in the summer of 2020, but that didn't do anything. And then also just that it spread pre-symptomatic. It looks like other viruses. It's really mutable, much more mutable than other coronaviruses, actually. And then you don't get sterilizing immunity, at least not yet, from our vaccines. So it can't be eliminated. So take that off the table. So then what do you decide about control? Unfortunately, control means the same mortality as other respiratory viruses. And by spring of 2022, Europe and the UK estimated that we had reached the same mortality rate from COVID than of influenza pre-2019. And that's when they declared, quote, endemicity, and they actually, their CDC hasn't looked back. They just put out a statement on April 27, 2022 that said it's endemic. We ended the global health emergency on May 11th, 2023 in the US, and the WHO ended it May 5th. But the reason it ended it a whole year after Europe ended it, the pandemic phase, is because of China, and because everyone was waiting for China to see what was going to happen, because they were having mass protests, and they did open up, and they opened up very abruptly on December 7th, 2022, and they had a very high mortality rate. So it was too much all at once without the boosting rates, I think, in the elderly that they needed. So that's all to say that, yes, the world has ended the pandemic because the WHO is kind of the authority on when to declare a pandemic over. And they did that on May 5th, but it is, and so we call this the endemic phase. It will always be here. It will go up if you have a new subvariant. It'll go up during cold seasons because it likes cold, and we go inside when it's cold. And that's when we need to boost older people and get our therapeutics out, because it'll always be with us.
And why does it go up in the summer?
It hasn't actually, it has not yet settled into, it actually mutates way faster than, again, in other coronaviruses. We used to call coronavirus DNA virus wannabes until now, because this is so much more mutable. So it came up during the summer because EG5 came up, and XBB 1.5 is only 3% of our species now. And EG5 came up, it was more transmissible, and then we got some cases, more cases because it's more transmissible during the summer.
It's driven largely by variants.
The variants, and it's really very mutable. So it may not always be in the winter. It'll be when a new transmissible variant comes, and it will be in the winter too.
Got it. Peter, what's your take?
Well, I think there are other reasons why this summer is also seeing a swell. I mean, I wouldn't call it a surge, it's an increase in cases that has been hypothesized. One, of course, is waning immunity. The second is people sort of traveling and getting together. But I think one emerging factor that people have called a mini winter is the fact that extreme heat drives people indoors. So it's kind of like winter behavior, even though it's called the summer, and all the evolutionary aspects that Monica talked about, so the variants, having highly transmissible variants. But this is the fourth consecutive summer of this swell, so are we going to see like a bimodal distribution with a little blip in the summer and a bigger increase in the winter together with the other viruses remains to be seen.
Yeah, and George made the point that the history of these kinds of things is the virus gets a little more benign over time and then just sort of is one of the viruses that we deal with. Is that because the virus is mutating to a more benign state, or that population reaches a state of immunity that it's able to fight the virus better, or both?
Oh, probably both. I mean, the evolutionary pressures to make more viruses and to make it more survivable. And the way you make it more survivable is to become more of a commensal parasite or a symbiotic parasite, rather than rather than being a high-grade pathogen. And that's the way the Andromeda strain ended too. I mean, I think we're driven a lot by fiction, by Michael Crichton's fiction from 1969, which is how this ended. It just got better.
Yeah. Okay.
But before, like OC43, that it had to rely on natural immunity, and it had to rely on it becoming less virulent. But now we have vaccines, so that made it, that really helped with all this.
And in fact, the OC
save mortality.
Yeah, the OC43 is, because it is circulating among children a lot. There is a thought that may have been why children had lower attack rates, because they had some partial immunity from the OC43.
All right, we'll get to the vaccine in a second and the boosters. Let's talk about the variants. George brought it up, but the scariant of the moment is the BA 2.86. And it's scary because you look at the spike protein and it looks like it's mutated up the yin-yang and very, very different than the spike protein we've come to know for the last 4 years. But I think there's a fair amount of research in the last week or two that's pretty reassuring. So do you want to just take us through kind of what we're thinking about this now?
Yeah, so the reason why people were so scared about BA 2.86 is that it has more than 30 mutations in the spike protein, which is kind of like where Delta went to Omicron, and we know what happened when Delta went to Omicron. So everyone's like super worried, even though it's not even reported in the variant map that George showed, because it's not that common yet, at least not picked up yet, more than 11 countries. But just over the weekend, we've had at least 4 labs around the world, 2 in the US, 1 in Sweden, 1 in China, showing that with existing immunity that we have, it can result in an increase in antibody sort of like neutralization against this scary variant. So people are calling it a paper tiger now because it looks really scary, but it's just made of paper. So whatever we have now will sort of neutralize it. But the interesting thing to me from the studies is not only the fact that we can neutralize it with what we have, meaning that the vaccine will work against it.
Your old vaccine or the booster
old
next
vaccine,
week?
or even people who have been exposed recently, because the XBB like immunity will work against this variant. But the other interesting thing, which speaks to the way the world is evolving, is the people who, the haves and the have-nots. And when I say that, I mean by immunity. When you look at the Chinese lab data, they performed a little bit less well compared to, say, Europe and the United States when they looked at people here. And it really speaks to maybe a hypothesis about why we're doing as well as we're doing given the number of cases, which is that, we just have a bigger immune repertoire based on all of these waves of infection. And China, has not doing as well because they've not been as experienced population-wise.
So China, because they did sort of a massive lockdown, and you can argue about sort of whether that was the right call from a humanity standpoint and ethics and all that, but one of the things it did was protect its population against getting infected. Our population, vast majority of people have been infected, and that infection is protecting even against this variant. And China, many people lack that protection, and therefore they may be more at risk because of this variant.
Yeah, so every time you get a vaccine, and particularly if you see real infection, you're seeing a different viewpoint. It's like you have a camera and it's taking like multiple pictures of the spike protein, and you just have a lot more pictures in the United States compared to China, which is just getting a very limited view. So when a new threat comes on board, you don't have confidence that everybody will be able to have that immune response to it.
Okay, and just one more bit of clarity, then I'll turn to Monica. So you made the analogy that Delta to Omicron had a similar amount of level of changes in the spike protein, and it led to a massive surge. And here we go from Omicron, whatever variant we were at, to this nasty-looking thing, similarly nasty-looking, and it seems to be a paper tiger. Is that just sort of math or physics? Like, what is it that determines whether it's nasty or it's not?
I think we don't fully understand because during the pandemic, we've had scary sort of alarms ringing out about lambda and all these weird looking things that look scary in the lab or in biology, but when it comes in the real life, it never really takes off. So we don't fully understand. One idea is that it really has to do with evolutionary fitness and how it dukes out against the other variants that it's competing with.
Mm-hmm. Monica, anything to add about it?
Yeah, the one other thing I'd add is that both the NIH and the CDC told us in November of 2022 that we had a lot of natural immunity. Essentially, we had 89.4% nucleocapsid antibodies. So 90% of people had seen not just the spike protein, because that's all you get in the vaccine, but 90% had seen the actual whole virus. So then you develop immunity against this part and this part, and the nucleocapsid. And so it's now we're not so reliant on spike cell changes, because just because BA.2.86 has a lot of spike cell changes, many of us, including you, have B cell, T cell, and antibodies against the nucleocapsid. And so it is the cumulative immunity that ended the influenza pandemic in 1918, likely with also less virulent. We got the less virulent with Omicron, as George showed us. We already had that. All these subvariants are less virulent, but now we have a profound wall of immunity, and the only place that didn't have natural immunity is some place that kept closed down, which definitely kept their infections low, but did have humanitarian, authoritarian aspects.
Just on the point that it has become less virulent, I see that debated in the literature. Has the virus itself become less virulent, or have we become more immune, and that the virus is less harmful to us? Do we know the answer to that?
Well, virulence is a two-way street. It's got the host and it's got the microbe.
Right. Yeah, you got to look closer. Yeah, there you go.
Monica was showing me the wrong way here. It's a two-way street. You have both the microbe and the host, and for whatever reason, that interaction, at least in the United States, which is where those data come from, is showing less virulence over time.
Right. But it's relevant, let's say, to China. If you have a population that's only 20% infected, not 90%, is the actual bug less nasty than it was by itself, forgetting about that the host has immunity they didn't have before?
I think it probably is less nasty than, say, the Delta strains, which are really nasty, right? The other thing is that the pandemic kind of playbook is that the reason you put the brakes on and try and slow things down is so that you can get everybody, so you can create a vaccine and get everybody vaccinated. They didn't do, they had the vaccine, they've had 3 or 4 vaccines, but they still had very low vaccine coverage. And that was, I think, the problem that
In China.
That's gone on.
Okay.
The best data on the less virulence, I think, is from Ravi Gupta's lab in UK, which is and Japan labs, which are infecting lung cells less well. It seemed like Omicron, just putting them together in non-immune people, Omicron couldn't affect the lungs as well, more up here.
And there's some, I've heard some
Exactly.
about 2.86 as well, that it, not only does it seem to be responding to the old immunity, but there's something in the lab that says it seems to be less good at infecting cells. I don't know if you've seen that.
We saw this with HIV.
That's what the Chinese data showed, and I think it's really, a little bit of both. We've gotten stronger, and the virus has not cared as much about entering that ACE2 receptor to get into the bloodstream.
Okay. Let's turn to the booster. As you say, looks like it's going to be out in the next week or two. Who should get it? Peter, why don't you start?
Well, I think the low-hanging fruit is definitely those who are older than 65 and those who are immune compromised of any age. I think that has been an emphasis in the UK, for example, those who are older than 60 in that population. But whether or not, but I think it will be offered to everyone, and but I think. And really, if you want to parse out who within that group should get it, it should really be those who haven't had as much immunologic exposure, particularly those who are unvaccinated or those who are very severely immune compromised, where I don't have confidence that they've had an immune response to previous infection or to or memory T cells and B cells to previous infection or to previous vaccination.
Let me pin you down. So looking at our in-person audience, I guess the average age is 30-ish. I also have 3 30-ish-year-old kids who are healthy. Some people probably are, some people are less so. And they come to you and say, I'm up to date on my boosters. I got my last one a year ago. My last infection was a year and a half ago or something. Should I get the vaccine? What do you tell them?
Well, I think it's complicated now because it's different for different persons, but if everyone had around the same sort of vaccines plus exposure, frankly speaking, I think that wouldn't be as important as somebody who was older, where we do have data that the immunity decreases the process.
I completely get that. I'm not gonna leave you until we pin this down. Clearly, it's less important. Clearly, at my age, I need it more than you need it, and you need it more than they need it. But you have a 30-year-old who's healthy, who got the booster. Let's say they missed last year. They got it 2 years ago, and they say, Dr. Chin Hung, you have given me so much insight in the last 3 years. Please tell me, should I get this or should I not?
As an ID doc, I think the answer simply answers yes.
Yes. Okay. Monica.
The reason actually I wrote this book was part of the question of trust in public health. And I am worried about the declining trust in our vaccine recommendations. I'm worried that 20.5% of people over 18 got the bivalent booster, the BA4, BA5 ancestral, because it means that people start ignoring recommendations. And 43% over 65 got the bivalent booster. I just looked this morning to confirm, not high enough, should have been 100%. So I'm actually more in favor of being very clean about who gets the booster or not. And I think we should go the way of the WHO. On March 28th, 2023, they put out the SAGE guidance. The UK's done the same thing. 65 and older, those on immunosuppressants, and those with multiple comorbidities. If you want it, I'm sure you can get it when you're 30, but I would go in that clean way, because when the world does something different and we do something different, and we are the only ones recommending it for the young, we were the only ones that recommended boosters for 6 months and up, then people stop listening, and that means we get less trust, and maybe they won't take their measles vaccine. So this book was an attempt to think about trust.
No, that's an interesting perspective, and I think very important sort of at a public health level. But individuals are going to make their own choices about their own risks and benefits. So if a 30-year-old, healthy 30-year-old came to you and said, I get this sort of trust thing, but I just want to do weighing risks and benefits myself, what you would tell them no?
No, I wouldn't tell them no. I mean, if they want it, absolutely. There's no harm, absolutely zero harm.
Okay.
The question is, HIV, we think more kind of like, do we make big recommendations so that we can get people to do trust?
But you're worried about the lack of trust because the recommendations are dissonant, but also that clearly the benefit for a 30-year-old is substantially less.
Yes, I think those
and you're giving a lot of
65 and
vaccines to
older,
people who aren't going to benefit all that much at all. Their chances of a severe case are very low, chance of hospitalization.
Yeah, the people who are still at risk for severe disease, I'm so worried about them that I want to really get the booster in them.
Population.
Yeah, I really want to.
You're thinking about it from a public health perspective. At an individual perspective, it sounds like you're permissive. If you want it, fine.
Right.
But if it's your kid, 30-year-old, Mom, should I get it or not?
I would say no, but my father has to. Yep. I would be consistent with what I'm saying.
Okay, George, where are you on this?
I think everybody should get vaccinated. I mean, the reason we parse vaccines is because there's a limited supply, right? If we have all those vaccines in the world, then we don't have a limited supply, and it's going to benefit people, with different amounts from 6 months of age and up. But if you do take the stance, which Monica very intelligently does, that we should be concentrating on the sickest people, you destroy the market, right? And this is not, these guys are now putting their own monies
That's interesting.
to this
So
vaccine.
you're worried about, will a vaccine manufacturer continue to stay?
Say, we're instead of giving out 100 million doses or 200 million doses, which, by the way, if you ever want to go into the vaccine manufacturing business, you should remember that anything that ever happens after a person gets the vaccine is the vaccine's fault. So it's just like nonstop litigation, but there's indemnification in the U.S., so that's a good part. But still, they
Yeah, but I'm not
base their
going to get
decisions
the
on-
vaccine to be sure Pfizer stays in business. I mean,
I was more worried about Moderna, but anyway. But
They're charging money for it.
They're
and
charging money
insurance will
for it,
pay.
that's
Yeah.
correct. But they don't want to end up with 97% unused.
But it sounds like, putting that aside, you believe that the benefits outweigh the risk even for a healthy 25-year-old.
Yes.
You do?
Yes.
And is that because of the efficacy in preventing a severe case? Is that because of long COVID? Is that because of you get however many months of protection against getting COVID in the first place? What's driving that benefit equation for you?
Yes.
All of that?
All of the above, yeah.
Okay.
I mean, I'm serious. It's this is the 6th leading cause of death in children in the United States, COVID, okay? It's the number 1 vaccine preventable cause of death in children in the United States. I mean, people get lost in the data, but there are some real issues here. Yes, it's uncommon. Yes, it's rare. Yes, it's relatively unusual. But so is poliomyelitis.
Yeah, yeah. Okay,
And
Peter?
I would say that 30-year-old today is not going, that 30-year-old in 5 years is not going to be the same as that 30-year-old today in terms of immune exposure. So it may be more important even for that person later on.
Okay.
And I'm
yeah,
sorry,
go
let me
ahead.
just one other point. Looking at the number of stethoscopes draped over people's necks here
Yep.
in this room, I mean, they also have a nosocomial transmission issue. And UCSF, by the way, requires bivalent vaccination. So I suspect, I don't know, maybe you know.
Will require this one?
Maybe they may
I don't know
well
if we know
require
that.
this.
I mean,
I would be
traditionally, we
surprised if
have
they did.
required vaccinations for COVID, like we do for flu every year.
But they require bivalent vaccination.
So the question is, I don't think it's known yet whether we're going to require that you keep up with this.
I would be surprised. I would be surprised if they did.
Yeah, I'm guessing that's true too. You mentioned flu, RSV, COVID. This comes up all the time. You should get all 3. Should get all 3 in one sitting. Get 2 out of 3 in one sitting. 3 out of. How do you parse this? Do you do some timing? I'm going to wait a little bit on flu because it peaks in February. What do you think about all that?
Well, so there's nothing wrong. I don't think there are any data that suggests you cannot get them all at the same time. You'll have a sore arm. You probably don't want to go try and play in the semifinals of the U.S. Open after you've done this.
With the windmill.
Yeah, you can use the windmill. Exactly. But I think that the timing of flu is always kind of an interesting thing. It's kind of a Goldilocks problem. You want it to be just right, right?
Yep.
You want to have your immunity peaking as the disease peaks. But, that's all about, kind of foretelling the future.
Yeah.
I always get it in October when it becomes available.
The flu vaccine.
Yeah, flu vaccine.
And so.
RSV should get the day it becomes available because
Okay.
there is some seasonality, but not a ton.
All right, so RSV, as soon as it's out, COVID, if it's out in 2 weeks, you would get it?
And by the way, RSV is for 60 and above or 32 to 36 weeks of pregnancy.
Got it.
Very
Okay.
limited groups.
Any differences in your thoughts about the timing?
I mean, the way I think about it is I will get, I think of it like the Olympics. It's COVID and influenza, like the gold and silver medalists, and then RSV is kind of the bronze medalist. So I would get COVID and influenza at the same time. And, I think the recommendation is to talk to your clinician if you're older than 60 to think about the RSV vaccine because it is the first year. It's probably going to benefit more the sickest of the over 60-year-olds. But you can definitely, as George said, get all 3 at the same time.
Okay. Monica, you were quite concerned about that.
RSV was really, really, really problematic last year because I think we had, really, we didn't have enough exposure to RSV over the previous 2 years. In
Right.
children, there was really quite a bit of illness. and older people are always at risk. And so I'm very, very excited about the RSV vaccine, 60 and over, and then pregnant women to protect neonates. And these viruses interfere with each other and they compete with each other. And I would almost favor RSV vaccine for an older person first, if I was actually competing them, because I know they have a lot of immunity to COVID. And I also know that I have treatments for COVID and I don't have treatments for RSV.
And if you're getting all three, would you get them all in one shot, or you?
Oh, I think that would be fine. Two of them are protein-based and then the mRNA-based, so it shouldn't be a problem.
Okay. I want to ask about your current behavior. This is not all of your behavior. This is COVID-related behavior. So, masking, restaurants, airplanes, what are you, in the face of a significant uptick in cases, but as you say, not a massive surge, when all of us have some measure of immunity from infection, often infection plus vaccines, what are you currently doing in terms of preventing COVID?
I'm currently doing nothing.
You are no masks anywhere.
I mean,
crowded indoor space.
In the hospitals,
in the hospital because you have to.
Yeah. Just guessing.
Yeah, crowded indoor space, fine.
Yeah, I mean, you can,
Okay.
Yeah, if you're going to be, crammed into some bus going across the country, yeah, I think that makes perfect sense.
Okay.
But, it depends on where you sit on the airplanes, all that
But
that
at this
stuff.
point, the state of the epidemic is such that you feel like your level of protection is such that you don't need to do any of that.
Today. I do.
And what would be the measure? Like, it's up a fair amount. Like, if that curve got to what point would you say, I need to do this?
I don't know, doubled maybe.
Double? Okay. I mean, it's double
Depends
now,
on
but
when
it
I
was-
can get the good vaccine. right?
Yeah.
If I can get the good vaccine and that's 2 weeks out, then I probably would.
Might be next week.
Yeah,
next week.
Yeah, and I'd say it's next. The over/under is next week, but it's next week or the week after.
All right.
But I would probably sit tight and
Okay.
not go to extraordinary lengths.
Okay. Peter, what are you doing now?
Well, I'm also similar to George, but I am carrying my mask around my pocket outside.
Doesn't
the
work
hospital.
that well in your
know.
pocket, I find.
It doesn't. But I'll give you scenarios where it might be helpful to sort of be a little bit more judicious. So I was visiting my mom, for example, who's 90 a couple of weeks ago, and I definitely don't want to expose her. So around that time, I'm being extra careful. So going on and off the plane or in the few days before, being more careful. And, a couple of weeks ago, Sam's dad was having a cataract surgery. So we wanted to be really careful because we didn't want to delay his surgery. Not that we thought he was going to get seriously ill because he's really up to date. But those are the kind of decisions you make around.
You're going to be exposed to vulnerable people.
Yes.
You're more likely to do it.
Because,
Is there some level of risk where you would say it's time to go back to my behavior of 2 years ago? I'm masking in a lot more places.
Only because it's disruptive. But I don't think we'll ever get to that point. I think we'll get to the point where you're working in a nursing home or in a hospital or in a prison, and you wear it when it's critically, there's a critical level of virus because you're protecting vulnerable populations.
But in just day-to-day life, you don't see yourself going back to a lot of masking.
No.
Okay. And Monica, you've generally been pretty non-masky for the last year, I know. Where are
Yeah,
you
I
now?
was super masky at the
I know you
beginning.
were very masky.
And then I became less masky. Yeah, I'm with George, but it's actually also partially that the data has been more clear on masks, and I think it has to be the kind of mask you wear, which when you really look at the Cochrane analysis of mask mandates off and on, just people wear masks all different ways, and it's going back to mask mandates.
So I wear a
public
K-
health
I
trust.
wear a KN95.
So I
Figure if
think
I'm gonna
you're
wear a
right.
mask,
Those are the
you wear a
ones.
decent mask.
Those are the ones. KN95, KF94, N95 fit tested.
George, a little skeptical.
And make sure you wear it over your nose.
Over your nose.
Right? It is
Yeah, I generally do.
An enormous number of people don't wear it over their nose. You want to say to them, you realize that 90% of your respiratory incursions are through your nose.
Okay, good to know. Vaccines for a second. We'll have questions in a second. Novavax, sort of a little hot in the news now about, yes, no. Where do you stand on it, Monica?
Well, You know, I actually kind of like Novavax, so partially because I like choice. So I'm again I'm always this HIV person thinking about COVID, and when we got more choice for prevention, it was better. And so we have only 2 mRNA vaccines in this country, and then we only have one other vaccine, which is protein based, and that's the Novavax vaccine. So it's a protein of the spike protein, and now they have XBB formulations coming in a couple weeks. With an adjuvant. And for those who don't want mRNA, then you have a choice. And I'm not saying that mRNA isn't a great vaccine, because I think they're very immunogenic. And I think mRNA vaccines are, for immunosuppressed populations, are really important, because they give you so much protein that if your immune system's down, you really can see a lot of protein to which to raise an immune response. So I would definitely recommend mRNA for immunosuppressed, but have a choice. And I think Novavax should stay around for choice.
But I'm going to get my, whatever it is,
You're gonna get mRNA.
6th or 7th vaccine shot in a couple of weeks. I might wait a little longer because I was infected 2 months ago, and I sort of figure I'm going to wait 3 months.
I really think you should, yeah.
Which one, and it's all been Pfizer or Moderna. Any argument for me to get Novavax?
No, I think that mRNA vaccines are the most immunogenic, and that's what you should get.
Okay, George?
I was just going to say, I mean, one virtue of the Novavax vaccine is that you're not dealing with myocarditis and pericarditis in adolescent and young males as a side effect. And I know Monica's spoken on this point quite cogently in the past, so not that you don't speak on it cogently now, too.
Or that she doesn't speak cogently about other things, too.
Yeah. Just trying to give credit where credit's due. But it's there's a real side effect with mRNA vaccine in adolescent boys, and we shouldn't deny it. And Novavax is a way out,
Yeah.
And so if somebody has pre-existing cardiac disease or has had a prior episode of viral myocarditis or something like that, that would seem to me to be a pretty good indication for it.
Peter, anything to add?
I think Novavax is a great vaccine, and I've seen a lot of people who have had, even though doesn't rise to the realm of anaphylaxis, some terrible sort of reaction, although temporary, to mRNA. They've been more amenable to getting Novavax. So I agree that it's great to keep it in the toolkit.
Okay. I'm going to ask a couple more questions, then I'll open it up. Long COVID and Paxlovid. Let's start with Paxlovid. Any changes in your thinking about who should and shouldn't get Paxlovid based on data that's come out in the last several months? Peter, do you still recommend it in the same groups you did?
I still recommend it in the same groups I did. Again, like the vaccine, I'll prioritize those who are older than 65 and immune compromised of any age with the main drug interactions. For those who are vaccinated, and that's of course the best data is in unvaccinated, but for those who are vaccinated, of course I do it because we can't really determine a lot of times people's risk. For those under 50, I think it just depends on the patient. I don't think we have great data saying that for those who are vaccinated or who have risk factors that it won't work. There is a suspicion that it wouldn't work quite as well, and it probably would work less well as we become more immunologically experienced. But that's the way I think about it. Of course, there's the observational data about lowering the risk for long COVID as well as Paxlovid. But
do you believe that?
I believe it. Yeah, I believe it because it makes sense biologically to me because you're kicking out the virus.
I'll push you again on that mythical 30-year-old healthy person who says, I know my risk of getting really sick and dying is very, very low, but I've read that if I take Paxlovid, my risk of long COVID is down by 30%. Should I take it?
I would say that's not a reason to take it for that 30-year-old because that person already has lower risk of long COVID by being vaccinated or exposed. And in the age of Omicron, we have just a couple of days ago, good data actually giving you the risk from Sweden of long COVID now compared to Delta and Alpha and the original, and it's less together with the U.S. Census data.
Okay. Monica, you same place in terms of Paxlovid?
Yes, I mean, we do, if you want to be truly data-based, which many people do, it's really only been studied in unvaccinated people at high risk of infection. That's the EPIC-HR trial, and then standard risk of severe disease, severe disease, and that's the EPIC-SR. And EPIC-SR, the results came out a while ago, it's just that they really told us more about it, but we already knew that the EPIC-SR study shows that if you're at standard risk to getting severe disease with COVID, Paxlovid does not help you. And we have to, know that and say that, and then say, okay, well, then what are the risks what are the groups that it benefits? It's the same groups that I think I was identifying for the booster,
Right.
over 65, comorbidities and immunosuppressants. And how do we know that? Not that we've studied vaccinated people in those age groups, but it is that observational data, this is, I think the best one is from Israel, says these are still the groups that are still at risk for severe COVID. We must do everything in our power to not let them have severe disease. I think that will help long COVID too. And so it's important to give them Paxlovid. So I will always go with those populations.
Great. Last question for me, then we'll open up. Anything we learned about long COVID in the last 3 months that's worth sharing? Peter?
I think just really that the risk is, we have more and more data showing that the risk is lower in this era compared to previous eras, and I think the data is just becoming more and more, giving you numbers and estimates around that, what we've been experiencing anecdotally, although it doesn't say that all the people with long COVID now are not suffering, because I still think it's a huge problem of the people who have it right now. The second sort of data, interesting data that came out recently was from the VA and Nature Medicine, the same St. Louis group, showing that, from the people who had long COVID in 2020, more than 3 years later, a proportion of them still have symptoms. So even though there's Israeli data showing that most people get better after a year, some people are still having symptoms beyond 3 years. But of course, that population may not be generalizable to everyone.
Okay. And I haven't seen any study that shows any effective treatment for long COVID. Is there anything that you've seen? Monica, do you have something?
Well, I thought the COVID out study, which was observational with metformin, was really important.
Metformin treating long COVID or preventing long COVID?
Preventing long COVID, but often if something prevents something like TDF-FTC with HIV, it can treat it. And so metformin is the postulated mechanism, because it's a diabetes medication, is that it lowers inflammation. And we always think that severe disease can cause inflammation. That's why we keep on looking at inflammatory pathways. And so I'm really hopeful about the recovery studies that just launched from the NIH, which are giving people in a randomized way metformin. Paxlovid will be one of the medications, and then other anti-inflammatory medications that we've studied in HIV.
There's another drug called Ensitrelivir, which has been approved in Japan. That's going to be probably a alternative to Paxlovid. It's also a protease inhibitor.
No ritonavir.
Yeah, so no drug interactions, once daily. I think that's probably maybe the future of early treatment. That has also been shown to decrease the risk of long COVID.
Decrease the risk,
Yeah, but not
at this point,
treat it.
there's no
Yeah.
drug that has been proven to treat someone who has actual long COVID and make them better. Is that's fair still today?
Just teeny little things like Benadryl and metformin that are teeny and not enough to say yes. So the randomized trials will have to tell us.
Great. Thank you. Let's open up. We have about 7 or 8 minutes to folks here, and then see if there are any online questions. Sasha, go ahead. Say who you are. When you get out there. Oh, Celia Mike? Yeah. Perfect. All right.
Oh, great. Hey, Saj Patel, I'm a hospitalist. Great to see you all in person. Question kind of germane to the mask discussion. What are your thoughts on universal masking in healthcare settings? And not, now they've said at UCSF, in break rooms it's okay to not mask, but with patient care it's required. And I believe other institutions, Stanford, et cetera, are not requiring it. It's optional now.
You want to take that?
The
answer is no.
That's a tough question. I mean, right now, I think given the fact that we are not asking patients to resist a mask, I feel, I know Monica may have different opinions. I feel like it's, given where we are right now, it still reaches that level where I would want a mask in a patient's room. But yes, I mean, I think things may change in the future. Some healthcare settings, like, Kaiser Center, brought back universal masks for patients and visitors, but I think taking an in-between approach in UCSF is probably not imprudent at this point. But again, to be reevaluated as we move into a different place.
Okay. Monica, anything to add?
I mean, going back to the Public Health Trust, I need to say it, because right now in LA County, Santa Rosa County, almost everywhere in California, they've stopped universal masking in healthcare because the California DPH said that you don't have to. And around most of the country and around the world, they haven't. And then when you get these hot spots like only San Francisco is doing something in Santa Clara and Alameda, and then no other place is doing it, you say, okay, what's the evidence? And there was a study in England that randomized half the wards to universal masking and half the wards not to universal masking, and the same degree of nosocomial transmission occurred. I think it really is around the question of trust. If you have those studies out there, maybe you need N95s for people with COVID, but the ship-shod way that we wear masks and the different ways that we wear masks, if it's not curbing nosocomial transmission, it will look, everyone will talk to their friends in Santa Rosa who are not masking and saying, I kind of want to smile at my patient in the room. So I'm going back to trust, I'm going on a population level, and that's my answer.
Okay. Yeah.
Quick question, Chris Nguyen. Couple questions. One, if I have a 3-year-old girl, right, and preschool and says if anyone in your household has COVID, your kid can't go to school, and obviously you can understand all the implications around that. And then also I have a mother who's like 80 something with diabetes and all sorts of comorbidities, never had COVID but had been vaccinated. So the basic question is, how much of a concern should I be around masking to prevent? Because the last thing I want is my kid to have COVID and have to stay home until they're negative in self-antigen, and then still work and all that stuff. And then exposure to parents who've never had the disease but only been exposed to the vaccine.
Anyone want to tackle?
Any recommendations?
We got a pediatrician here. What do you think about the?
So I think it's highly unlikely that your daughter's going to get COVID from you coming home from the hospital. I mean, she's going to get it from all the other kids around her and everybody she comes into contact with every day. So she's the one if you're going to go down this path, she's the one who's going to need to be masked. The chances of a 3-year-old wearing a mask correctly aren't zero. But to quote tomorrow's headlines from Dr. Chin Hong, it would be not imprudent to do it that way. But it's the likelihood of success is going to be very low. You can make the case that the daycare centers have gone way overboard on this, which they kind of have. But again, they have to protect their clientele. They have sort of these larger liability issues that they have to deal with. For your mom, what's going to protect her is you being vaccinated and she being vaccinated, and that's the bottom line.
Yeah.
And then it becomes belt and suspenders.
And we haven't really talked about testing at all. Is there any role for him to get tested before he sees his 80-year-old mom who hasn't had COVID yet? Monica?
Well, this is so important to talk about it right now because Jill Biden got COVID.
Correct.
And Joe Biden and his press secretary are talking about the CDC guidance in a very skeptical way. So they're like, Biden's taking off his mask and saying, don't tell the CDC I did this. And so, and I think the reason he's doing that is...
You meant the California Department of Corrections, by the way.
Well, the reason I think that's actually really important is to say that it may be time to update the guidance from the CDC about testing and how long to mask and how long to isolate, because when the President of the United States is kind of sidelining those guidelines, we're a little bit out of touch with the rest of the world. So the rest of the world is sort of trying to say stay home when sick. That really is an endemic respiratory virus protective measure. In general, just always, we didn't do this as healthcare workers 3 years ago. You have to stay home when you're sick. So, but at any rate, I would say that testing, yes, it could be helpful. The one thing is you could test negative in the morning and test positive at night, so it's not a guarantee that you're...
Although the White House is still testing people before they...
And then they're
wanna
saying,
meet
and then they're
Joe
muttering to each other.
Just the old 5-day thing that you feel better, but you're still testing positive. Are you infectious? Should you go out? Can you go out with a mask? Peter, what's the recommendation now?
I think you can go out with a mask until day 10, unless you test negative, and then you can exit that. Although I must say that there are lots of countries in the world where they've gone to an influenza model where you stay home when you're sick and then you go out when you're not feeling sick. And whether or not the U.S. will move to that.
But is that right? My sense is if you're still testing positive, you're still infectious.
Yes.
So
Well,
It's a calculated risk.
It's a little harder to tell just because viral culture may not still be positive after
Yeah.
5 days, especially if you have a vaccine because it kills it, but you can still have viral particles.
but day 10, I think for sure. I mean, because there still are people who are testing
Positive on day 10.
positive
Yeah.
long after day 10 and they're staying isolated. And I really think it's okay not to be isolating or protect, after day 10.
Lakshmi, we'll have time for one or two more questions. Anybody have?
There's a couple of people who are confused if the new booster is bivalent or monovalent.
monovalent. It's XBB 1.5.
Slight correction. One of George's slides, but
Yeah, I was just looking when you were talking, they're all XBB
It's now just purely-
1.5.
Got rid of the alpha, okay, my mistake.
It's all for simplification. And I think that might also,
Peeling off of the old CDC
Yeah.
websites.
The ancestral strain is so ancestral.
no, but
It's gone.
the
It's
simple,
not around.
yeah.
Yeah.
all right, Lakshmi, anything else?
And then there's a couple of questions about travel, taking Paxlovid with you for travel, mask mandates in healthcare settings, which you've addressed.
To travel. You're going to Europe, you're going to Asia, you take Paxlovid with you?
Yeah,
Yeah,
I do, and I take test kits with me.
and test kits with you.
If you're immunosuppressed or older, I would take Paxlovid with you. for
I
sure.
would definitely prescribe it to any of my relatives and take it with me. You don't want to be stuck somewhere else and not have health care.
Okay, I think we have time for one more. Yeah.
I just have a question about hypercoagulability in COVID. I know, for example, as a resident, when we work at the General, we're asked to get a D-dimer on everybody who has COVID, and if that's positive, to start them on therapeutic anticoagulation. And my understanding is that data is based on the initial studies with the original strain of COVID, so I'm wondering, I guess, your perspective on that. I always feel uncomfortable as a resident prescribing my patient heparin drip when all they have is a positive D-dimer and COVID.
All right. Peter, you want to take that?
I think your sense is right. I do feel that the risk is different from the ancestral strain for all of these other complications like hypocoagulability. Even when you look at the MISC data in kids, it dropped by half when you looked at original versus even 2022. So I think that, personally speaking, I'm not sure the juice is still worth the squeeze.
I'll talk to the general.
That will be fixed at the General by this afternoon, probably. All right. Yeah, no, this is a tough issue because you have a practice pattern that was set early on with a given virus, and the virus has evolved, and it sounds like that thing happens less often. We should quit. Thank you all for coming, folks who are here. Thank you all online. We'll be back again next week, and we'll keep doing this hybrid, so I hope a fair number of people decide to come here, eat lunch, and see each other face to face. Thanks very much. Be well.